Well, good afternoon, everybody, and welcome to today's session, which is entitled Adapting to Innovation in Pediatric Acute Lymphoblastic Leukemia, Guidance on Optimizing Modern Therapy and the Role of Novel Asparaginase Compounds. Dr. Schore and I are really excited to be here today in person, which is pretty neat. We also want to recognize that there are a lot of people who are joining us virtually as well, and so hello to everybody. Today our panelists are me, Stuart S. Winter, and Reuven Schore, and we want to thank everyone at PeerView for helping us to provide this session, and to Jazz Pharmaceuticals for providing the educational grant for the symposium. We have a couple of survey things to fill out, and please look for additional follow-up with polling during the presentation. Submit your questions and we'll try to answer them during the question and answer session. You can do that online and on the iPads that are at the tables. We just wanted to point out that this is an accredited event, and so people will get credit for attending. For my disclosures, I am a consultant for Jazz Pharmaceuticals. How about you, Reuven?
I am as well a consultant for Jazz Pharmaceuticals.
So we also wanted to say that we will disclose any unlabeled use of some of the products that we might discuss during this presentation, and hope to have an interesting conversation about how we are adapting to innovative therapies. Importantly, you can visit us at peerreview.com/ALLP22 to download the slides from this presentation. And there's a couple of slides that are kind of complicated, and so we'll want you to download those for your future reference. So I'm going to just start with the asparaginase story. And as maybe some of the people in the audience know, asparagine is an amino acid that was first isolated in asparagus, and so that's where it gets its name. Interesting phenomenon is that developing lymphoid cells are entirely dependent on serum or CSF concentrations of asparagine. They can't make asparagine themselves. And so asparagine is a necessary ingredient for the synthesis of nucleic acids in cell division. And if this unusual situation did not exist about asparagine in lymphocytes, we wouldn't be having this talk today. That's how fundamental that odd finding is. Asparaginase itself deaminates the amino acid group circled in red, and that's the asparagine amino acid. I should also mention that asparagine deaminates glutamine as well in the same phenomenon. So let's go back in time to 1961, when a group of investigators looked at the effects of asparaginase in an anti-lymphoma model and found that they could interfere with cell division, and they could get serum levels of asparaginase in the animals that they were testing. This then led to a case report where a group of investigators gave asparaginase to a patient in 1966 who had a response, and white count went from 18,000 to 4,000. The lymphoblasts decreased down to 14%. The patient's liver decreased in size, and his testicular enlargement also decreased in size. And you can see that these values are shown in the figure to the right. So what this goes to show is that asparaginase is a cornerstone for ALL treatment, but because it's a protein, it's discontinued in up to 25 patients because of toxicity, which includes a number of things we'll talk about later. Asparaginase was pegylated to make it less obvious to the immune system, and so it's been used in first-line formulation for a long time in high-income countries. And recently, Erwiniak chrysanthemi was approved for use in 2011, as an alternative to patients that have hypersensitivity to PEG asparagase. What's important to me about that is that I was running the 0434 TALL study from 2007 to 2014, and it was a great relief to the study committee that we had an alternate form to give of asparaginase to give to patients that had problems with it. And so all of this was recently summarized in a paper that talked about asparaginase over the last 50 years. I just wanted to point out that there are some new types of asparaginase that we're working with. And the one that we're going to be talking about throughout this conversation is PEG asparagase, all the other asparaginase across the top of the slide, including Erwinia, and now a recombinant Erwinia that was approved in 2021 to be given as 25 milligrams per meter squared IM every 48 hours. And so that's the latest one to join the team. What this slide is showing is that intensive asparaginase treatment improves clinical outcomes. And if you'll notice in the slide, the gray bar shows treatments that were used using more intensive asparaginase, and the blue bars less intensive asparaginase. And you can see by the numbers embedded in the bars what the outcomes were like in terms of percentage of EFS. And basically the message across the slide is that more asparaginase generally worked better than less asparaginase. So more is better than less. But this is a really important study that came out in the year 2020 by Gupta et al. And it basically reports outcomes in patients and where the asparaginase couldn't be given for some reason. And you can see by the red dotted bar that where there was discontinuation of asparaginase, there was a decrease in event-free survival, which turns out to be a really important finding to the asparaginase story. And I have to say, as a treating clinician, when I had patients that I could no longer give asparaginase to, I thought, well, you know, they're getting dose-intensified therapy. Maybe it doesn't matter that much, but this paper shows that clearly it does matter, and that it's a really important drug in our repertoire of chemotherapy. So what are the challenges that affect asparaginase delivery today? They fall into two main categories: drug shortages and unique toxicities. During the pandemic, we all became very aware of pipeline issues or supply chain issues, and that also affected the asparaginase story. There are unique toxicities related to the asparaginase, and there are also unique physiologies that we're working with here. Children handle asparaginase differently than older adults. Many of our colleagues that are medical oncologists find that they really can't give asparaginase to people who are in their fourth or fifth decade just because of some of the toxicities that are associated with these drugs. So getting back to shortages, here is the website for FDA drug shortages. And you can see here that Erwinia was on that list based on this data. And then in terms of toxicities, here's sort of a basic breakdown of what we're looking at. Hypersensitivities are probably the most common, followed by pancreatitis, hyperglycemia, hepatotoxicity, and thrombosis. So that's kind of the list of things that we kind of have to work through as we try to maintain dose intensity with this class of drugs. So in today's agenda, we're going to have an introduction on where we stand with asparaginase therapy and ALL, and then we're going to have a case discussion where we're going to follow a patient through several scenarios and talk about treatment options and treatment barriers. So it's my great pleasure to introduce Dr. Reuven Schore, who will then take over the presentation and walk us through the first aspects of our case history.
Thank you. Thank you very much. And it really is very good to be here in person after so long away. Start with a clinical consult of patient Michael with T-cell ALL. an obese African-American teenager who begins a 4-drug induction based on the ALL 1231 protocol. So just a question to ponder as we go on is, what risk factors does Michael have for asparaginase-related toxicity? And second question is, should dose capping be considered for this patient? So one of the things that we've learned, as Stuart pointed out, more asparaginase is better for outcomes, but too much asparaginase can cause problems. And the adult oncology community has been very focused on dose capping asparaginase when given, often caps at 1 vial size, which is 3,750 international units. And the question in the pediatric community, as we have more and more patients with high body surface area and obesity, should we think about whether some of these patients would benefit from dose capping without affecting efficacy? So this paper looked at the effects in terms of toxicity based on BMI of patients. And you can see that BMI diagnosis that's greater than the 95th percentile was the only finding that they found significant for increased toxicity. And this particular toxicity is looking at conjugated hyperbilirubinemia. This here looks in both obese and non-obese. Both obese older patients greater than 10 had the highest risk of severe hepatotoxicity and of clinical pancreatitis, followed by older children and then obese younger children. So particularly in those obese teenage patients, we need to think hard about what we can do to minimize their toxicity. This is a pediatric paper focused on patients who received doses under that dose cap that's often used by adult oncologists of 3,750 international units as compared to those above that dose cap. And we see that the incidence of thromboemboli, pancreatitis, and hyperglycemia are all increased for patients that received higher doses. One thing to note about this paper is this may be a surrogate that's really looking at elevated BSA and obesity, because this did not look at patients of the same BSA that were dose capped or that were not dose capped. That being said, we do have evidence to suggest that patients even that receive dose cap still receive enough asparaginase to be highly efficacious. Children's Oncology Group recently included dosing modifications for patients that are both older than 21 years of age and for patients that are obese. The standard dose that we've been using for quite a while is 2,500 international units per meter square per dose. A newly approved dosing for adults through the FDA was for 2,000 international units per meter square per dose. And then just being sure to consider for patients who have an elevated BMI to consider using a dose cap to try to avoid excess toxicity. Do you want to take a brief digression into talking a little bit about asparaginase levels, which will be helpful as we go through our cases? As Dr. Winter explained, asparagine depletion is really how asparaginase works, and probably, ideally, the best way to measure the efficacy of our therapy. That being said, asparagine depletion is very challenging to measure in vivo due to ex vivo depletion. And so we've generally used serum asparaginase activity as a surrogate marker of the efficacy of our drugs. The exact therapeutic level of asparaginase activity that is needed has been the subject of a lot of different papers, and there isn't a clear answer for that. The levels greater than 0.1 are generally considered efficacious. The FDA has used greater than 0.4 in some of their studies, but there's still a lot of room to try to sort out what actually is needed. Serum asparaginase levels do go down over time, and so you can see in this graph that many patients have levels above those cutoffs for at least 20 days or so. This second chart looks at, in yellow, looks at PEG asparagase and cal-PEG asparagase in blue at the dosing, and you can see that many patients remain therapeutic above those 0.4 and 0.1 for upwards of 25 days.
But just as an important point is that if the serum asparaginase activity level drops more than one would expect, it can sort of suggest that you're looking at a situation of silent inactivation.
Yes. One of the things we tried to do, and this is a trial that we worked on looking at patients who received PEG asparaginase and who had asparagine levels at the same time as asparaginase levels. I mentioned some challenges with ex vivo depletion. We worked pretty hard in this trial to try to minimize that, as well as checked CSF asparagine levels, where the ex vivo depletion is not a concern, as asparaginase itself does not cross the blood-brain barrier. And what we found is that in patients who had an serum asparaginase level as low as 0.02, all of those patients had asparagine depletion and it had it undetected, whereas in the few patients that had a level less than 0.02, but even though it was measurable, did have asparagine detected. And that, I think, calls into question whether you absolutely need to be 0.1 to be therapeutic. That being said, I think that still is the number that's generally considered acceptable. A few interesting patients we did see as part of this trial. These are the two patients that did have detectable asparaginase but still had asparagine repletion. And we can see when this patient had a level of 0.36, they still were depleted for asparagine, which is in the dark blue. And then as the level got down to 0.014, the asparagine became back to the baseline level. And the same is seen with the second patient. That being said, we also had some patients with very low levels, somewhere between 0.08 and 0.3, all of which are below that 0.4 value that the FDA has looked to for approvals of asparaginase products, and each of them had no asparagine, even with those lower levels. Getting back to Michael, Michael received a cap dose of PEG asparaginase on day 4 of induction. 1 week later, an asparaginase activity level was obtained and was 0.607. And I will say from clinical practice, that's fairly common. I think most patients that we check a level about a week after asparaginase are somewhere in the order of 0.6 to 1, which is certainly super therapeutic. On day 20 of induction, that patient develops a persistent headache and nausea. MRI shows sagittal sinus thrombosis. I think brings up a couple of questions about how one would manage the thrombosis, both acutely and in the long term, and then what to do about future doses of PEG asparaginase that this patient would be due for. Stuart, what your experience in practice would be?
Yeah, so at my institution, which is Children's Minnesota, we would attempt to try to reverse this clot with TPA and then start a low molecular weight heparin. And in our experience, that usually works pretty well. At my institution, we have generally then we have intermittently used low molecular weight heparin during subsequent courses of asparaginase just to prevent the clot from recurring. That's usually followed after about 6 months, 3 to 6 months of just giving the low molecular weight heparin. But as this audience knows, you have to kind of work around spinal taps with low molecular weight heparin, and so we've tried to kind of use it sparingly when we think it's safe. How about you, Dr. Schore? Yeah. How about at your place?
So I'm at Children's National. We similarly would consider directed thrombolytic therapy and then start a patient on low molecular weight heparin. For a sinus thrombosis like this, we would typically continue that for at least 6 months, and would also cover the patient at least prophylactically, if not for therapeutically, during times of future PEG asparaginase doses, both starting with the dose and for a couple of weeks thereafter. And as you pointed out, we do struggle with keeping the platelets up, and patients needing more platelet transfusions during that time. But as we've discussed, showed earlier from Gupta's paper, omitting PEG asparaginase in these patients is associated with a worse prognosis. So we try our best to get in all the doses that we can get in safely.
Yep.
Can I just comment one?
Please.
I think the biggest challenge we are facing in scenario like this is maintaining the platelet counts, especially during consolidation and delayed intensification, where it's hard to maintain platelets above 50,000 because the new protocols are so intensive. And I have seen a lot of discontinuation of low during that time. So looking at the risk versus benefit, I don't know how feasible that is to continue low molecular weight heparin, especially if you have a stroke. And then the risk increases when you're not able to continue it because the half-life is only 24 hours.
Yeah, and so as start with that, I think you definitely are challenges in terms of maintaining the platelet count, particularly in those more intense parts of chemotherapy. I think during the first 3 to 6 months after thrombosis, we try very hard. We sometimes have patients coming 2 to 3 times a week if needed to keep their platelets up. I think that does cause us to think about whether after the clot has resolved and in just the prophylactic setting, if we should consider using Lovenox at a prophylactic dosing instead of a treatment dosing. And in that setting, our hematologists have been comfortable with keeping the platelets over 30, which is a little more manageable.
And to your point, sometimes trying to keep platelet counts above 50,000 does sort of interact with like when you start the next phase of therapy. And so I've seen some institutions try to, if they can, build in another week of recovery just on a case-by-case basis. But it is a challenging situation.
Yeah, and just another little summary slide of some of the range of asparaginase-associated toxicities. And some of these toxicities do affect our ability to continue asparaginase therapy and do delay therapy overall. I think one of the we're going to talk about some of these as the case continues, but one of the things I do want to highlight specifically is hepatotoxicity and hyperbilirubinemia. This is a particular finding that, speaking to adult oncologists, they're quite nervous about and often is a reason that asparaginase is not even given to older patients. But I think particularly in our obese patients, Hispanic patients, this can be a significant problem and can delay other systemic therapy. There has been some anecdotal evidence and some retrospective evidence that levocarnitine can be useful in either preventing or reversing this hepatotoxicity. And the Children's Oncology Group, in cooperation with some of the adult groups, is working on a prospective trial that hopefully will be opening soon, looking at levocarnitine both through prophylaxis and treatment of the hepatotoxicity.
I did have a question for the audience and for those online, and I'm just curious if anyone has patients where they feel like the asparaginase is making them either cachectic or lose too much weight. I've seen a couple cases of that in my career, at least I think I have. I'm just wondering if other people have seen anything like that. Yeah. There's
40% of his weight almost during induction, and there wasn't anything. I mean, you're expecting him to gain some weight for the steroid or something like that. He didn't have severe hyperglycemia to explain that.
Right.
We were giving him NG tube feeds, so it was really hard to get him back on track.
Yeah, and I've had a couple kids like that too. And to Dr. Schore's point, we'll talk later about what can we do to kind of control some of those symptoms with levocarnitine or acetylcarnitines. But yeah, I think it does come up. Anyway, back to you, Dr. Schore.
Sorry, how will you say it's asparaginase, because there are multiple agents which are there. It's very difficult to judge because doxorubicin can do that. I mean, daunorubicin, your Cytoxin, Araci, I mean, all those can cause bad nausea, vomiting, you can lose weight.
Right.
So how will you pinpoint with asparaginase? Because it's never used as a single agent.
Yeah, good question. In my experience, where I got that impression from is the patients were saying, I was doing okay, I was eating okay, and then I got that dose of that drug, and man, I just couldn't look at food for a while, and so it was like that direct kind of interrogation of what happened after a dose.
Just getting back to a little bit of some of the management of thrombosis after asparaginase. The incidence is between 3 and 5% in children, and most of these are occurring in induction, although they can occur at later time points. And well, the risk does appear to be similar regardless of asparaginase products used. Generally, I think the most important message is manage the clot as you would manage a non-asparaginase related clot, and then in general, in most cases, after clot stabilization, with continued anticoagulation, you are able to resume asparaginase dosing. We should have some questions on your iPad and virtually that you can answer at this point, and I'll turn it back over to Dr. Winter.
There is one that popped up on my iPad here, and it's about, the question is, what about the subset of patients that are not able to get due to TPA and weight is one question that comes up. And then earlier in the presentation, there was a question about how do you dose asparaginase in patients with borderline high BMI. Do you want to take either one of those questions, Dr. Schore?
Yeah, I think that the borderline high BMI, I think for the patients that are high BMI, I do think that thinking about dose capping is very reasonable. As I mentioned, most patients with that we check levels 7 to 10 days after are usually in the 0.6 to 1 range, which is probably super therapeutic. And so I think it's very reasonable to think about dose capping for patients that are at that higher range.
And then I'll just briefly say that in patients where I haven't been able to give TPA, we've tried to just use low molecular heparin with lots of follow-up, but again, we do try to use TPA when we can. Okay, I'm going to take it over here and continue on with our discussion with Michael. And so here he is again. Michael receives day 15 consolidation PEG asparaginase by IV infusion, and then he develops nausea and mild flushing 10 minutes into the infusion. And so, Dr. Schore, if you get this page in clinic, what are you thinking when you're going into that room?
Yeah. I think when the symptoms of hypersensitivity reactions have to be differentiated from the symptoms of infusional reactions, or often caused by hyperammonemia. And I think that can be very tricky at times. But I think when I hear nausea and flushing, but I don't hear rash, I don't hear breathing difficulties, I think more of hyperammonemia, and try to do a physical exam to assess that, and before deciding what to do about that.
Yeah, it's probably one of my least favorite pages to
yeah, at about 4 o'clock Friday afternoon.
Yeah, that's when it happens too, yeah. All right, so as Dr. Schore just said, based on lack of what sounds like classic hypersensitivity, we would want to think of this first as an infusion reaction. And so that, in my clinic anyway, results in a pause in the infusion, monitor for improvement, restart the infusion at a slower rate, and try to calm everybody down, because that's usually what that situation looks like. All right, so during the next section of the presentation, we're going to kind of toggle back and forth between hypersensitivity and infusion reactions, because they can be kind of hard to differentiate from each other. So as this audience knows, asparaginase, it's an enzyme, it's a foreign protein, and because of that, it can provoke an immune response. In many cases, hypersensitivity is manifested by anaphylaxis or allergy. And so what that looks like in the clinic is swollen lips, urticaria, sudden difficulty breathing, things that look like that. Hypersensitivity reactions are associated with immune destruction, but mostly what they do is they make it so that the asparaginase doesn't work anymore. And as you all recall from the slide that I presented from Gupta et al., we want to make sure that people do see the asparaginase dose intensity that we're looking for on our studies. So there are two sort of alternatives. Well, there are two basically types of asparaginase that we've been working with that generally kind of tee up the problem for hypersensitivity, and that's native asparaginase. It was very highly associated with hypersensitivity reactions, up to 60%. Native asparaginase is not available in the United States right now, but it's still being used in parts of Europe. As it shows here in the second bullet item, If you give it with corticosteroids, which dampen down the immune system, you see less of those problems. Because of all the problems with native asparaginase, asparaginase was pegylated to make it less immunogenic, and so it works that way. But the incidence of asparaginase hypersensitivity reactions have ranged quite a bit, anywhere from 3 to 36%. So a lot of variation in that. So this is a paper that I was on with a number of authors that I thought was really a nice way to look at hypersensitivity reactions. And so, as you can see from the data there, we looked at 54,000 doses of PEG given on a number of COG studies for both B-cell and T-cell disease. And as you can see from the bar graph there, most of the hypersensitivity reactions happened with the second or third dose, which is usually consolidation. So that's where that all happened generally. The committee kind of thought, true hypersensitivity reactions are pretty rare during induction, and that's often when kids are getting steroids and seeing those drugs for the first time. But yeah, it was consolidation where most of that happened. So interestingly, the IV prep of a PEG asparaginase was associated with less true hypersensitivity reactions, which I have to say at the time shocked us, because we thought that the IM would be a little safer. And in fact, during my fellowship, I was trained that if you give PEG IV, you're going to see immediate hypersensitivity reaction that you can't control. And so there was a lot of drama around making that switch and a lot of discussion at meetings. But I'm glad that we persisted with asking the question, because you can see the answer was not what we thought it would be. And it's a highly significant finding with all of that.
And I think one of the things that is interesting, and I think as you're probably about to get to about infusion reactions, I think a lot of those first dose reactions probably were infusion reactions that weren't really detected. I know you mentioned the paper that reported 36%.
Right.
I knew that on the COG trial that first gave things IV, we had quite a few reports of first dose reactions, and they just didn't make a lot of sense. The one thing that is interesting is that the PEG part of PEG asparaginase is in a lot of cosmetics, and large numbers of American and European populations do have PEG allergies.
Yeah.
And so a small percentage of them might be PEG-related allergies, although I think probably the vast majority of them are actually infusional reactions.
Right, and to add to your comments, Dr. Schore, when we first started doing this and we were telling families we're going to give this PEG asparaginase IV rather than IM, I think a lot of families were like, I'm not really sure I want to do this. And so I feel like, in some cases, people were just really hypersensitized, at least emotionally, to kind of and a change in how we did things. So infusion reactions, like I said, we're going to toggle back and forth between these two topics. They develop during or shortly after the IV infusion. It's a release of cytokines or histamine, activation of the complement. But I think mostly it's just a sharp elevation of ammonia levels. And as I said at the beginning of this talk, asparaginase deaminates things, asparagine and glutamine, and that NH2 group comes off, floats around in the bloodstream, it picks up a couple proteins, and it turns into ammonia. And ammonia makes people feel bad. And so I think that's a little bit of some of those infusional things. And actually part of why sometimes people just don't feel well after getting some of these drugs. So hypersensitivity versus infusion, timing, antibody reactions, most likely second, third doses, as we just said. Infusional reactions with first exposure. But there is a lot of overlap, and one of the ways you can try to differentiate some of these phenomena from each other are serum asparaginase activity levels. And so I have an algorithm that will do that in just a couple minutes here. So I won't read every word on this slide, but some of the things that can be looked at in a clinic setting when you're asked to evaluate a situation is that infusion reactions tend to more commonly include things like headache, flushing, diffuse erythema, but not diffuse urticaria, rigors, and in some cases, kids just saying that they have trouble breathing. And as I read through that slide, I was highlighting on all the things that are in red there. If you look at hypersensitivity, there's in the dermatological category, it's pruritus, urticaria, things that kind of go along more with what you'd expect to see with an allergic reaction. So this too is a bit of a complicated slide, but I think it's an important slide. And as I said earlier in the talk, that you can download this information. I think this is a nice algorithm that would allow someone to distinguish a hypersensitivity reaction from an infusion reaction. And it does it based on the evaluation of serum asparaginase activity levels. And I believe that there was one of the questions in the chat already about how do you do that. And so I hope I might have just addressed that right now by saying that just measuring these levels can be helpful in kind of deciding what your next step is going to look like. So anyway, I think it's a really helpful slide. So pre-medication, and again, there's a couple questions in the chat about, do you pre-medicate or not? And so that's become kind of a current topic over the last 5-10 years. They are used to prevent infusion reactions, like I said before, with histamine release, that kind of thing. And so what people tend to use for pre-medications are things like famotidine, methylprednisone, Benadryl, and Tylenol. Interestingly, there's a lot of differences in how people use those different drugs to kind of protect against some of these phenomena from happening. And you can see from the bar graph on the right, pre-medication tends to improve the tolerance of PEG asparagase, and that was reported by Cooper et al. In 2019. So like I just said, practices vary. I'm curious, Dr. Schore, what's your practices at your institution for pre-meds?
Yeah, so at Children's National, we do medicate all patients receiving asparaginase products with diphenylhydramine and famotidine. For patients that are getting steroids as part of their chemotherapy, we do not give additional steroids, but for patients that are in a phase that doesn't include steroids, we do give hydrocortisone. The hydrocortisone was a more recent addition, and we're in the process of analyzing the data. I'm not completely convinced that the hydrocortisone did change things, although I do think that the pre-medication overall changed things. And then we do routinely check therapeutic drug monitoring with asparaginase levels between 7 and 10 days after each dose of asparagine.
Yeah, and I would say that what I've seen in my career is that for a while we were trying not to pre-medicate patients because you didn't want to cover up a reaction and not know that you had some kind of a silent inactivation process happening. But then the use of therapeutic monitoring became more widespread, and we were able to kind of tell which one was which. And so I think that's been a really nice advance over the last few years.
Yeah. Just add one thing just to mention. I think that advent of the ability to send asparaginase levels and get results very quickly has helped a lot.
Yep. And
we do check things about, as I say, 7 to 10 days after the long-acting asparaginase, and we typically check after before the second dose for patients that are getting a short-acting product.
All right, so let's go back to Michael. Michael is now at day 22 of consolidation. As you may recall, he's our 16-year-old African-American male with T-ALL. He's in consolidation, and he complains of abdominal pain, nausea, vomiting. An astute person checks his amylase and lipase levels and finds that they're 3 times higher than the upper limit of normal, and the ultrasound shows that he has acute pancreatitis. So recommendations for this are to admit to the hospital, bowel rest, IV hydration, and follow these patients really carefully. I guess the question comes up is, do you want to re-challenge after something like this? So here is a paper from Wolders et al. From 2017, and it basically just looks at what's the incidence, and it's 5 to 10% of patients. And certainly in my lived experience, the severity varies quite widely when it occurs. But as you can see here, as you look across the bottom of this graph, you can see death due to asparaginase-associated pancreatitis. And there are some dots in the yes column. And in my career, I've had a couple patients that really, really got sick with pancreatitis, spent a month or two in the hospital on TPN. And it's a big challenge. It's really, really tough when it happens and when it happens really badly. There are some cases, though, where it seems to be sort of a minor event. And so just to kind of talk about re-challenge after pancreatitis, the incidence of recurrence after re-challenge is it's pretty high. It's about 50%. And I guess there are ways to make this decision using CTCAE criteria to kind of distinguish how bad is it. The second episode might not be as severe, but I think Dr. Schore and I really talked carefully about this slide before presenting it. We really think that you should assess risk versus benefits of re-challenge with your team, hopefully to include a clinical pharmacologist or other people that can really help try to keep your patient out of trouble. Do you want to add anything to what I'm saying?
Yeah, no, I think this in general, we spoke a lot about the importance of asparaginase. I think pancreatitis is one of the side effects that has a lot of us pretty scared given the incidence of recurrence. I think,
right.
One of the things that comes up sometimes is some belly pain with imaging that's not suggestive of pancreatitis, but with the elevated amylase and lipase, and the patient may or may not have concomitant constipation or some other cause of abdominal pain. And I think in some of those patients we have re-challenged locally and been successful. I think in the patients that have had, significant hemorrhagic pancreatitis, pseudocysts, and real problems, we have been very cautious and generally have not.
Very good. And I think somebody asked a question kind of about this in that chat, and I hope that we answered your question. So moving on with Michael, he receives PEG asparagase on day 43, and he develops highs and shortness of breath 30 seconds later. And how would you manage? And so, well, we think that you have to make a decision here because we think that this patient has a hypersensitivity reaction that's pretty obvious. And you can't keep giving PEG asparagase to a patient who just did that because, it's not going to turn out very well. So you are at a decision point. And so with your teams, we would want you to consider the pros and cons of switching to either Erwinia or to a desensitization protocol. Talking about these two different forms, there's no cross-reactivity between E. coli and Erwinia. The switch to Erwinia asparaginase for the remainder of asparaginase courses can lead to definitive allergic reaction. It can also have inactivation issues, and TDM is helpful for managing that. So the current conversion excuse me, is for every 2,500 units of PEG asparaginase replaced with 6 doses of Erwinia at 25,000 units per meter squared. So the big question then becomes, what if Erwinia is not available? And that was really very much a big question over the last couple of years. So because of some pipeline issues, because of some supply chain issues, the question of desensitization really came to the forefront of our science. A number of papers came out on how to desensitize patients with PEG asparaginase allergic reactions because, as we discussed earlier, not maintaining asparaginase intensity really does lead to inferior outcomes. And so it forced our hand as a community to come up with some way of kind of managing this, and that's what all these papers are saying here. And so let's say that Michael tolerated desensitization with premedication, had to replace the day 43 dose of a PEG asparaginase, and then we looked 7 days later, and it's 0.01. So obviously, desensitization did not seem to work very well in his case. How would you manage it? Dr. Schore, you want to comment on what you're thinking here?
Yeah, so I think, this, apparently desensitization worked because you didn't have clinical symptoms, but I think in the setting of a level 1 week later that's well below the level of therapeutic benefit, I think that patient didn't really get benefit from that, and I think it's time to switch to an alternative Erwinia product.
So silent inactivation, no clinical manifestations, but you do see loss of serum asparagine activity levels. And so here's kind of like the guidelines for what to look for. And as you can see, at 14 days, if it's less than 0.1, you probably need to find something else. So we're going to talk a little bit about recombinant asparaginase here. And recombinant crisantaspase is produced in Pseudomonas. And we're just going to call it recombinant asparaginase from here forward. The primary amino acid sequence is very comparable to the Erwinia, and it is now currently approved as a component of multi-agent therapy for the treatment of leukemia in both children and adults who have developed hypersensitivities to PEG asparaginase. So in this particular study, SAA was used to monitor effect, and you can see on the left there's Erwinia at 25,000 units per meter squared, and then there's recombinant Erwinia to the right, and they had very comparable decay curves in that particular experiment. And currently, recombinant asparaginase has been through a number of dosing evaluations, both IM and IV, and currently, if you look at how many patients had levels greater than 0.1 with 25 milligrams per meter squared IM, all patients did. And so it looks like it's a drug that can replace Erwinia because you can't get the Erwinia. As Dr. Schore mentioned earlier in our talk, if you're looking at levels of greater than 0.4, that was not preserved with this particular drug. But again, there's a lot of discussion about what is the right level to pick. So this is a phase 2-3 study. It's now in a point where it's being evaluated for both IM and IV. And based on PK and safety data, the recommended starting dose is 25 mg per meter squared IM and 37.5 milligrams per meter squared IV on Monday, Wednesday, Friday is what is being evaluated and looked at very carefully right now. So the dosing is showing that the efficacy is maintained in these phase 2 and 3 studies. And so an IM dose of 25 milligrams per meter squared on Monday and Wednesday and 50 milligrams on Friday appears to demonstrate a good benefit to risk profile. And it appears to maintain good serum asparaginase activity levels at both 48 and 72 hours based on the data that was presented at ASH last year. So I'm going to just take a couple minutes and see if anyone has any questions about recombinant asparaginase or Erwinia before I present the last few slides in the deck here. Any questions from the audience? I will say one thing. At my institution, we're using the IM dose of 25 milligrams per meter squared Monday, Wednesday, and 50 milligrams per meter squared on Friday. I have had a couple of patients say that the Friday dose is tough, that they really have a tough weekend because of just not feeling well. And so we're now looking into a couple of options of trying to provide levocarnitine or acetylcarnitine to help ameliorate some of those symptoms. And so I think that's the focus of an upcoming COG study, is to look at how do we make the patient journey a little more pleasant. And I wonder if other people are having that experience. Are you seeing anything like that at your place?
Yeah, so
Dr. Schore?
I will say the FDA approved dosing was 25 every other day. And we actually, for patients that are not on protocol or that were not on this initial recombinant Erwinia protocol, using that 25 milligram dose every other day, which is logistically challenging because we have patients having to come in on the weekends to complete their 6 doses. We did have a number of patients on the 25-50 dose as part of the COG protocol, and I do think that a lot of those patients had problems with that Friday dose. And I think, you mentioned earlier about weight loss and poor weight gain, and I think a lot of times patients that were getting that regimen, particularly when they're not on steroids, or even when they are on steroids and you'd be thinking they'd be eating
they're not.
Just not.
Yeah.
And particularly over the weekend, which I think also, alluded to one of the questions asked earlier, how do we know it's asparaginase? I think that sort of timing makes you suspicious of that.
Exactly. And so I have a patient at Children's Minnesota who was getting this particular regimen, and I passed him in the hall the other day, and I said, so, hey, how did your Friday dose go? And he said, it went great. And I said, oh, that's really good. That must mean that the levocarnitine is really working. And he said, no, I refused to get the 50 milligram per meter squared dose. I got the 25. And so I'm like, okay. And so, for patients that are young adults who can say no to things, I think we just have to keep in mind that, we really do have to partner with them to keep them, getting drug doses that we think are acceptable and will help them. But, we really do have to be mindful that these conversations are happening in the hallway, and they totally matter because patients can say no, and we don't want that to happen. So I'm going to just present a couple more slides here kind of quickly, but I just thought this was kind of cool stuff, kind of state of the art, and I just wanted to put this out there, is that recently people have become interested in using genomics to predict who might have PEG hypersensitivity or any kind of asparaginase hypersensitivity reactions. And so as this audience knows, human leukocyte antigens are really an important part of our genome that help to determine self versus non-self. And it turns out that DQB1, DQA1 are really involved with mediating asparaginase anaphylaxis. And this is from a paper by Deshpande et al. From 2021. And so this led to further work with this group of investigators to look at what was the effect of PEG asparaginase hypersensitivity in a large population of patients. We looked at almost 5,000 different patients, and some from St. Jude, some from COG, BNT together. And what we found was that if patients were HLA-DRB1, DQA1, or DQB1 negative, they had a rate of hypersensitivity of about 11% or so. If they were triple positive, though, for DRB1, DQA1, and DQB1, you can see the right-hand bar there shows that they were twice as likely to have a hypersensitivity reaction. And if you look at the p-value, it was 2 × 10 to the -7th power. This study was done largely in children and young adults of European ancestry, and it just got me to thinking, well, what is it like in other ancestral groups? And I think that's the basis of a really important future study to look at, is this the same for everybody or not? And so I kind of feel like this is kind of a future direction we should look into. So I just want to say we're getting kind of close to the end of our presentation today. On your iPad and virtually answer questions. Please take a moment to answer follow-up profiling questions on the management of barriers to effective asparaginase. Use it in pediatric ALL. Just please proceed to do that, whether you're here in the room or online. Dr. Schore, I'm going to kick it back over to you.
So just sort of wanted to give a little summary on some take-home points. Asparaginase is a critical component of ALL and lymphoblastic lymphoma therapy. There's a unique toxicity profile that can be challenging at times to manage and figure out the different potential causes or the different potential events that might be occurring. Hypersensitivity is a common reason for PEG asparaginase discontinuation, and it's very important to try to replace asparaginase that has to be discontinued with alternative therapy, because we know that strongly affects outcomes, particularly in high-risk patients. And we need alternative asparaginase availability. That certainly has improved greatly with recombinant asparaginase. I know, speaking to patients over the years, when we wanted to replace patients with Erwinia and didn't have it, was a very great challenge for both clinicians and patients. So it's good to have that availability.
All right, I think we have about 5 minutes left for just questions. And again, we have a few that are in our queue here that we'll start we'll try to answer here in the next minute. But don't forget to visit it at peerreview.com at /ALLP22 and submit your post-test and evaluation for credit. Again, you can download these slides, and thank you so much for joining us for the presentation part. So let me jump to the first question that was posed about an hour ago, and the question is, what do we recommend for establishing, determining the severity of hypersensitivity? Question, is it CTCAE or are there other tools? In my experience as a study chair, it's really using the CTCAE tools to do that. And as a matter of fact, at Children's Minnesota, we're using that particular tool to help differentiate between low-grade versus high-grade hypersensitivity reactions, low-grade maybe being a portion to desensitization, and high-grade maybe just going over to recombinant Erwinia. The trick will be, of course, is getting everybody to follow those guidelines, but that's our intent. So, Dr. Schore, you want to take the next one? Which asparaginase toxicities are more prominent or troublesome in children versus adults? Any thoughts on that one?
Yeah, so I think most of them are probably more, I think most asparaginase toxicities are probably greater troublesome in adults, and I'll also acknowledge I'm not really treating too many adults, but just in speaking to our adult oncologists. I think that our older teenagers also have some of those adult-related problems. Particularly risks of hepatotoxicity, I think, are very significant in those older populations, those obese patients. And I think, speaking to adult oncologists, besides their routine dose capping, I think over a certain age, depending on the oncologist, somewhere between 30 and 50, they just won't give asparaginase at all and will rely on non-asparaginase-based protocols.
Well, very good. Next question, I'll take this one. Premedicate or not to premedicate to prevent allergic reactions? As I think I said before, we do that at Children's Minnesota. There is also a COG website that pharmacists can kind of put in their practices. I looked at that website data a few days ago, and it felt to me that of people that self-reported, around 80% of people were premedicating, but there were some sites that don't. Again, practices vary. I will say that at my place, we premedicate. So Dr. Schore, how about the next one for you? How do you approach lower grade AEs such as subclinical or laboratory pancreatitis, if you want to take a shot?
Yeah, I think the subclinical or the laboratory pancreatitis is probably the one area where we often will re-challenge. I think wait for those to resolve, and assuming those resolve in some reasonable time frame, typically will re-challenge. I think the clinical ones are a lot more concerning for me than the subclinical.
Very good. Next question in queue. Could you discuss the risk of a tall, thin adolescent with a BMI greater than the 95th percentile? Is that person's risk the same? So, my sense of BMI is that when you dose on BMI, you're not just dosing the person's serum and CSF with asparaginase, you're dosing their liver and a lot of other things, and livers are not necessarily keeping up to speed with the person's overall BMI. So I kind of feel like, at least this is my opinion, I feel like going off the BMI probably is something that can help with organ sparing. Do you have any thoughts on that?
Yeah, I think the tall patient who doesn't have an elevated BMI but has an elevated the patient that has an elevated BMI, I do think that there's reason to be concerned. I also think the fact that we have a lot of evidence that most patients at that higher range are getting very high levels from lower doses, I think it's an area where you can definitely consider dose capping and consider following levels just to make sure you're still getting the efficacy that you want.
Great. Next question is, we premedicate every patient getting asparaginase. Can you comment on that? And I would say yes, we do the same. We do the same at my place as well. Dr. Schore, over to you. Would you adapt or intensify premedication protocols ahead of consolidation?
Yeah,
so you would personalize it for the patient.
Yeah, I think, so the only difference that we do is in consolidation, we do give hydrocortisone, and we don't do that in induction when patients are already on steroid. I don't really think there's other ways to really tailor that.
Yeah. Excellent. Next question, I'll take a shot at it. I've heard that drawing a tryptase level can be helpful in distinguishing hypersensitivity versus infusion as well. Is that true? And I have to say, I don't know the answer to that. I don't.
Yeah, I have not used tryptase levels. I think ammonia levels can be helpful, and often if, one of the things that we try to do to try to help distinguish this is we actually have one of the leukemia providers by the bedside whenever we start a patient on asparaginase, just so if there is a reaction, which usually happens pretty quick, someone's around sort of that's better trained to assess that. And if we have a reaction that we're not sure about, we will draw an ammonia level immediately after shutting off the infusion. And sometimes that can help us because a very high ammonia level can give us an answer, but I've not used tryptase levels.
So, I think we're at time, and I want to be respectful of the time for people in the audience and online. I wanted to say I really, really enjoyed being here today. I loved the discussion we had with the audience and people online. And again, I just really want to thank the organizers for inviting Dr. Schore and I to present today. Dr. Schore, do you have any concluding comments?
Yeah, I wanted to also similarly thank everyone for being here and thank PureView and Jazz for arranging this. I hope that everyone got something out of this and certainly encourage people to continue the conversation.
And have a great meeting.